Everyone, welcome. Today we are talking about a really important topic because it is Pregnancy and Infant Loss Awareness Month, and we're so delighted to have Caitlin Skeens with us here today to really walk us through this topic and to allow us to share and also to ask questions, as well as to learn a lot about, how we can support bereaved parents during this time. So Caitlin is a local clinical psychotherapist located in the West Valley, and she specializes in the diagnosis and treatment of perinatal and postnatal mood and anxiety disorders. Raised in the beautiful Pacific Northwest, where I think she is today, Caitlin, her husband, and their children relocated to Arizona in 2017 to be near their most supportive family members, her in-laws. Her personal birth stories, encompassing loss through miscarriage and 3 live births, inspired her commitment to empowering, supporting, and nurturing mothers and families through fertility complications, healthy pregnancies, and the turbulent transition of the perinatal and postnatal periods. Caitlin is dedicated to promoting the wellness of families with compassion and grace. And you can find her at Sage Wise Wellness. Thanks so much for being here with us today, Caitlin. I'm really delighted to have you. I think this is a super important topic, and I'm so glad that you're willing to talk with us about it.
Oh, thank you, Jenny, and thank you for that introduction. This is a topic that is very close to my heart and something that is kind of difficult to talk about. So I'm happy to shed whatever insight that I can provide. I'm going to go ahead and share my screen now so that you all can see my little presentation here. Okay. And oh no.
We're all good with tech challenges.
Okay, I apologize.
No worries, no worries.
No apologies, Caitlin. This happens to best of us at every presentation.
Of course it does. And that's okay.
Even in our conferences, it happens.
Yeah, I figured this, just my luck. That's okay.
There we go. No,
we can roll with that. That's all right. Okay. Here we go. Can everybody see pregnancy and infant loss awareness? Slide
Looks
one.
Good. Thank you.
Okay. Sorry about that, everyone. Yes. So I believe too that this topic is of unique importance, in particular this month as well, in recognizing that the month of October is perinatal loss awareness month, drawing attention to this. So I'm really excited to be talking about this today. And Jenny did such a lovely introduction, and this is just, to kind of snowball up of that a little bit. I am a perinatal mental health specialist. I am certified by Postpartum Support International to treat and support women and families through the perinatal period. This passion drove me to start my private practice in 2020, in which I dedicate all of my time and resources and everything, all the passions that I have towards supporting this dynamic and people who are in this season of life. And that's my kids. And I'm a mother of 4 with 3 living children, a bereaved parent, and a personal survivor of perinatal depression and anxiety. Just a content warning for this presentation, because it does contain inferences, details, photos, and accounts of experiences with pregnancy and infant loss. We're going to be talking about miscarriage, stillbirth, birth trauma, fertility challenges, fetal congenital abnormalities, termination of pregnancy, as well as perinatal mental health struggles. So as I said, October specifically is Pregnancy and Infant Loss Awareness Month. And this has been recognized on a national level since the late 80s by presidential declaration. It was stated that October be designated to recognize the specific and unique kind of grief that bereaved parents experience. The purpose of designating this is, yes, to create awareness and to talk about it more, but also to recognize what these families have lost, and to educate families about things such as prevalence rates and other details that are not common knowledge, and also to provide families who may be struggling with this. And so I have down here in the corner a banner from the Star Legacy Foundation. The Star Legacy Foundation is a nonprofit organization that is dedicated to their work is in this issue alone, and these stated purposes. And there will be, I'm going to discuss this a little bit more at the end, but their website is where you can access banners and images if you have an interest in sharing that on social media to contribute to this cause and increasing awareness, recognizing loss, and so on. Say their name. So at the end of this presentation, there is going to be a moment where we're going to recognize the loss of those children that were born asleep. And I would just like to invite any of you who either yourselves or your family or someone that you know have experienced a perinatal loss. I invite you to, in the comments, just you can choose to type a name or a date or anything that you would like stated out loud to be able to recognize that life. And I will read that at the end when we observe our moment of silence to honor those babies. I'm going to start out talking about attachment, right? That's the reason that perinatal loss is so challenging and difficult to cope with, because we become attached. We become attached immediately. Attachment forms in an instant, and not always, but in many circumstances it does. And from the moment of a positive pregnancy test, the pregnant person or the family, they begin to envision a lifetime, constructing a narrative about what this lifetime will look like. It's an instantaneous phenomenon for many people. And there's 3 specific forms of attachment that start in utero. It's emotional attachment, behavioral attachment, and cognitive attachment. Now, when we're talking about emotional attachment, this is wondering what your future child will be like. Maybe you wonder what they'll look like. Maybe you wonder what kind of a relationship you'll have with them. Maybe you daydream about inside jokes that you may have with them as they become older. Any number of emotional connections that are imagined and start very early. And then you have behavioral attachments. So these are behaviors that parents will engage in that strengthen this attachment relationship. And this starts in utero as well. And so here we're talking about maybe a family or a parent that wants to be able to provide better for their growing family. And so they get a different job, or they purchase a safer vehicle, or they begin hunting for cribs and various things like that. So behaviors that people engage in that strengthen the attachment between themselves and their growing child. And then we have cognitive attachments. So these are the thoughts that come about as a person thinks about what their child will be like as a member of their family. This is wondering, what sort of traditions might we have as a family? How will our family be the same or different when this person enters? And so all of these things start almost instantaneously for many pregnant people and families. It's the earliest form of parenting that we do. And as I stated, I keep mentioning families and partners as well, because this is not just the pregnant person. This is the partner as well. And partners and fathers, they develop this oftentimes in a different way than the pregnant person does, but they develop it as well. in various capacities. So now I'm going to talk about prenatal detachment. Okay, so prenatal detachment is most often this occurs after a pregnant person has experienced a loss before. And because of that previous loss and the difficult and conflicting emotions that they're struggling with, they may engage in this prenatal detachment where they avoid these emotional, behavioral, and cognitive wonderings that grow and foster early attachment relationships. And that can be really challenging. So I want to define this term perinatal, just in case, some of you are not familiar with it. So perinatal encompasses preconception all the way through 1 year postpartum. I believe the medical term for it does not include preconception, but in the mental health world, we do consider preconception as being part of the perinatal period when we are talking about attempting or trying to conceive. And I've created a little timeline here so that we can talk about what perinatal loss looks like at the different stages. And starting out discussing preconception, like I said, we're talking about fertility struggles here. And then between conception and 20 weeks fetal gestation, a perinatal loss is a miscarriage. Between 20 and 40 weeks gestation, we're talking about a stillbirth. After 40 weeks and up to 28 days postpartum, the first 28 days of life, a perinatal loss in this time frame is called a neonatal loss. And then after the first 28 days of life, we refer to this as infant loss. And so I just want to give everyone a quick reminder that this is a difficult topic to discuss. And I hope that you will check in with yourself throughout this presentation and recognize within yourself if you are feeling potentially triggered or needing to take a break, needing to walk away. I encourage you to practice good self-care and have awareness of what's going on with your own thoughts and your own body as you're listening to this content. So fertility challenges. I'm going to begin talking about fertility challenges. And you may notice that I have stated numerous times fertility challenges or fertility struggles. And I don't in here state infertility. And there's a reason for that. In the mental health world, it is a term that can be very difficult for women and families to hear, because when we talk about the word infertile, it is an identity term. A person is infertile. It takes on an identity. It can cause a lot of intensely negative emotions. And so for that reason, you will hear me refer to struggles with fertility as fertility challenges throughout this presentation. When appropriate, I would encourage any of you talking to people who are struggling with this particular issue to do the same if you're able to do so. Other times that's not possible because infertility is a medical diagnosis. And as I understand it, the medical diagnosis is often required if somebody is going to be approved to receive fertility treatments or anything like that. And so the medical definition is an inability to conceive after 1 year of trying. Or if the woman is age 35 or older, it's after 6 months of trying. And the CDC defines this as also an inability to carry pregnancy to term, whether we're talking about multiple miscarriages or stillbirth. And so I want to talk about prevalence. Fertility challenges are a lot more common than people think. 10% of American women will experience fertility challenges in their lives. That's a lot of women. We're talking about over 6 million. Over 6 million US women will struggle to either conceive or stay pregnant during their reproductive lifetimes. This is also 1 in 8 couples. About 20% of women in the United States right now are having their first child after the age of 35. And some of that can certainly be attributed to struggles with fertility. I don't know how to make those notifications go away at the top. Sorry, guys.
No worries.
Okay, treating fertility challenges. So fertility is specifically treated by a reproductive endocrinologist. This treatment can be highly inaccessible. There's many reasons for that, mostly because it is extremely costly financially. And many insurance policies and companies don't cover it at all. And if they do, it is minimal. And so it's inaccessible for the majority of women who are in the middle of the struggle. Struggling with fertility and going through the process of treating it can result in the pregnant person or the person trying to conceive internalizing a sense of body hatred, frustration, and hatred with the fact that their body isn't working the way that they wish it would. Another interesting fact is that if we're looking at this from a medical standpoint, fertility is 50% male factor and 50% female factor. If you look at the statistics, it's about half and half. Yet, regardless of if a particular couple is treating for male factor infertility or treating for female factor infertility, the female is always the identified patient. And so that can contribute to this, the internalizing and shame feeling. Shadow losses. Shadow losses are a loss of expectations. And somebody on a fertility journey often experiences a sense of loss around missing out on a typical experience. You may think the typical experience is an excitement of getting a positive pregnancy test and having the opportunity to share that with friends and family. It just doesn't happen that way when someone's on a fertility journey. Sometimes they feel as though they've been cheated out of the way that things are supposed to be, and that can feel really difficult. And if they are able to successfully conceive, the pregnancy and sometimes even the parenting experience may not meet their expectations. There's oftentimes a dismissal if the couple is able to conceive of their previous challenges with fertility struggles, and they may hear comments such as, well, now you're pregnant and that's everything that you wanted, and so everything is fine now. And yet they may not have really coped through all of those early challenges on that fertility journey and may still be grieving some of these shadow losses. Now with new technology in fertility, we see multiples far more often than we have, in any other time in our recent history. And this can be a shadow loss as well if someone who is conceiving through the assistance of reproductive medicine conceives a multiple pregnancy, a twin or a triplet pregnancy when they preferred to have just one. And that can be a loss of expectation as well. I'm going to talk about this in the context of identity. So maternal identity is oftentimes coupled or can be perceived at times as synonymous with someone's identity as a woman and feminine identity. And this certainly isn't true for everyone. But when it does apply to people, it's oftentimes because it is something that is so ingrained in them from a very early age. When a young girl grows up in a family where she is with a biological mother or has a mother present, from a cognitive, childhood development standpoint, the child's primary attachment figure is going to be her mother, especially in the first 6 years of life. And just inevitably, we're talking about a girl's primary attachment figure being a mother. The only person she identifies with as a primary attachment figure for the first 6 years of her life is a mother. That's all she knows. And so with that, she then decides to seek that as her own identity or not. But regardless, it can be a difficult transition no matter what she chooses, because if she chooses not to mother, that can be a very difficult sense of identity to shift and to do something different than what your own mother did. And kind of writing your own story can be a challenging path. And then if the woman does choose to become a mother, then there's this sort of very intertwined sense of being a mother is what you're supposed to do, because that's what my mother did. And I was always given baby dolls, and that was the message, is that you're supposed to have a baby. This can really shake a woman's confidence. Also, too, there are studies that affirm that women who have struggled on a fertility journey, they adjust less well to their role as a mother if they are able to conceive and bring a healthy child into the world. It can be a very isolating experience. We have a very parent-focused society. And so someone who is struggling with fertility is going to be hyper aware of everyone around them who's pregnant, everyone around them who is making pregnancy announcements, things you may not even realize, such as all the back to school advertisements. Those can even be triggering. Another identity piece of this journey is that it can consume the woman or the couple who is on it. They can become so engrossed in the journey that they forget who they were before and are striving for an identity that they want, that they forget who they had. Some special considerations. We talk about secondary infertility here. So secondary infertility is when a woman meets criteria, that medical definition for infertility, but has already carried a pregnancy to term. And that can be really difficult because the woman herself and or people around her may wonder, well, it seems as if you can conceive, and they don't consider that she may be on a fertility journey, even though she's conceived and birthed a child before. There's also a pretty dismissive divide that exists between fertility struggles and pregnancy loss. And this is sort of just one of the unspoken things that a lot of people on fertility journeys talk about. They feel as though there is a judgment, whether it's inferred or perceived or direct or what have you. They feel as though the message is that you didn't actually lose anything if you never conceived in the first place. They feel dismissed. Families struggling on this fertility journey often feel a very deep sense of depression, and they often lose hope. And we're also, talking about a significant strain on relationships when a couple is on this path. So that's fertility. So now we're going to move on to talking about miscarriage. And as we talked about before, this is a pregnancy loss that occurs between conception and the first 20 weeks of gestation. Talking about prevalence. So 15 to 20% of clinically recognized pregnancies. So that means a pregnancy that you can see on an ultrasound. So 15 to 20% of those will end in miscarriage. 80% of these pregnancy losses happen in the first trimester, 14% happen in the second trimester, and 6% in the third trimester. And then if we look at prevalence rates just within maternal age, if we're looking at pregnant people at about age 20, about 20% of pregnancies end in miscarriage. And at the maternal age of 40, it's over 40%. Now, these these numbers may seem a little bit odd when we're looking at the clinically recognized versus what I have noted down here when we consider early losses. So if we consider early losses, which are often not clinically recognized, that is from the positive pregnancy test, but maybe not anything is recognizable on an ultrasound yet. That would be considered an early loss during that time period. And late periods. If we consider early losses as well, it's as high as 50 to 70% of all pregnancies will end in miscarriage. And so that's where that 20 and that 40% come from when we're looking at maternal age more specifically. And then, so including early losses, that's 1 in 3 women will have at least one pregnancy loss in their reproductive lifetime. And 1 in 36 women will have 2 or more pregnancy losses in their reproductive lifetime. And so this is a lot of people. This is a lot of women. This is a lot of families that are dealing with this. And even if we are just in a room with 3 other women, it's likely that one of us has a story to tell. Fact versus fiction. So what actually does cause a miscarriage? The most common is an embryo, chromosomal, or genetic issue unique to what is specifically happening at fertilization with this specific egg and that specific sperm. And it's not a genetic issue with the mother or with the father. It is just a situational, specific chromosomal issue. That's the most common. After that, about 10% of the time, it has to do with a uterine anatomical issue, followed by about 10% of the time, we're talking about an immune issue, or 10% of the time, it being a hormonal issue. Very rarely, we have balanced translocation genetic issue, and that's with either parent. But over half the time, there's no issue with the parents, and it is a circumstantial thing. About 80% of women, I don't have this written on here, but about 80% of women will go on to carry a pregnancy to term after a miscarriage. Things that do not cause miscarriages are activities of daily living. Scrubbing your floor on your hands and knees, driving, anything that is part of just normal daily living does not cause miscarriage. Typical life stressors do not cause miscarriage. Diet is not proven to have a contributing factor to miscarriage. Exercise within reason, it being too much or not enough, does not. In and of itself, having had a previous miscarriage is not a risk factor or a cause of another. Working doesn't cause miscarriages. And this doesn't include exposure to harmful chemicals. Sexual intercourse does not. Having negative thoughts about your pregnancy does not cause or contribute to an increased risk of miscarriage, nor does air travel. So debunking some of those myths there. How does it feel? Well, it can be really difficult to internalize the fact that a death has occurred. It can be very hard for the person to wrap their head around. We have this trend in our culture where people don't announce their pregnancies until a certain gestational period. And it can be considered, taboo or shameful in some way to announce your pregnancy too early. But then if you don't, you're going through this alone. And if you do announce it, you now have to explain to people who ask you how you're feeling every time that your pregnancy has ended. It's often a very intense and sudden shattering of expectations. Remember, we talked about that attachment forming instantaneously for many women, and that life imagined being shattered all at once. That's what it often feels like. A lot of women report feeling an intense sense of guilt. They may find themselves apologizing or explaining to other people who they feel expected a baby. Maybe that's parents, in-laws, siblings. They may wonder, did I do something to cause this? Women who've experienced miscarriage also report a really high level of shame, feeling as if they are defective or bad, and that there's something inherently wrong with them that caused this to happen. Another experience of the person going through this loss of pregnancy is pretty considerable physical pain and discomfort. Miscarrying a pregnancy at any gestational period is a physically painful and uncomfortable event. It can be very isolating also, in the sense of, if others didn't know that you were pregnant and now, ergo, others don't know that you're miscarrying, there's no one around to talk you out of these self-blaming belief patterns, right? Whereas in other circumstances, when we're going through something and we are talking with our friends and we say something such as, I just feel like it's my fault, right? And our friends say, of course it's not your fault, right? But if we're going through this alone and people didn't know that we were pregnant or didn't know that we're having a miscarriage, there's no one there to talk us out of these. And we're alone with these thoughts, and they turn into rabbit holes and often become very internalized. Also, this parent-focused society again, right? Like the commercials, all the pregnancy announcements that you hear and see, maybe noticing if, people who are in a different season of life than you are conceiving seemingly easily and carrying pregnancies to term. People who have experienced a loss of pregnancy are at a significantly increased risk for perinatal mood and anxiety disorders. Most specifically, when we're talking about miscarriage, women who experience miscarriage are at risk for two particular perinatal anxiety disorders: perinatal PTSD and perinatal OCD. So let's talk about the language and the narrative that we tell around pregnancy loss. So everyone understands what the story is supposed to look like when we have a positive pregnancy test. We know what comes next. It's a common story. But when someone's experienced pregnancy loss, there's a very abrupt deviation from this. And women who are in the middle of the story oftentimes don't know how to talk about it, because they've been on this well-traveled narrative that makes sense, and it makes sense to others and it makes sense to them. And then they are abruptly thrown off of it, and they now are not really sure how the story goes. There's also this language around the safe zone to just make it to 12 weeks. And it's really, it's harmful to use this kind of verbiage for a plethora of reasons. Most importantly, it's because there is no safe zone in pregnancy. And by doing this, we're creating an overwhelming sense of anxiety for women who either have had pregnancy loss or maybe haven't, and they're just fearful of pregnancy loss. The high anxiety in the first 12 weeks, and then following that, maybe feeling blindsided by a pregnancy loss that may come after 12 weeks. There's also this word miscarriage. It implies a miscarriage, meaning carrying incorrectly. If you miscarried your baby. It implies fault and blame. It's very likely to impact the woman's self-esteem and her worth as a woman. The medical term for miscarriage is spontaneous abortion. It can be very difficult for women to hear. That word has a very strong context, and many women report feeling extremely triggered and bothered and experiencing a stress response when hearing that word, spontaneous abortion, in a medical context with regard to what they're experiencing. Another common narrative following pregnancy loss is others telling the couple, you can try again. And that can feel very dismissive of the loss. There's some medical implications here too. Certainly not all, but there are many in obstetric care that will not see women in a certain period of time, such as we won't see you until you're 8 weeks along or something like that. And that can feel dismissive, almost saying, we don't want to invest in you until we know if your baby is viable. And that can be very difficult. At the time of a miscarriage, that becomes the end of your provider's medical interest in you, not for the fact that they don't have interest in the woman as a person, but simply their medical expertise is no longer medically relevant to the woman. And it is sort of this abrupt ending of a relationship where for the woman, it's likely a momentous event. And yet she's having a separation from her care team at this time. This feeling of feeling no longer medically relevant. Just another aspect of pregnancy loss at the first 20 weeks is at times the woman may need to have a D&C to have the uterine lining cleaned out if she's not fully past all the tissues. And that can be a very difficult procedure to have to go through. And also too, talking about the state of our world right now, I'm sure every hospital does things a little bit differently, but from what I understand, oftentimes women are doing this procedure without their support person present. Okay, so I just want to give everyone another reminder. Check in with yourself, notice how your body's feeling, notice if you're having any visceral reactions to anything that we're talking about. Practice good self-care. If you feel that you need to or want to take a break, please do so. And we're going to transition a little bit now and talk about stillbirth. So stillbirth is a loss of pregnancy between 20 and 40 weeks gestation. There's 3 different kinds of stillbirth, and early is between 20 and 27 weeks. It's considered a late stillbirth if the loss comes between 28 and 30 weeks gestation, and a term stillbirth if the fetus is 37 or more weeks gestation. This happens 1 in every 160 live births. In the year 2014, there were 24,000 stillbirths reported in the United States. There is considerable variability by race, and I'm going to talk about that in a while. Many of these are preventable stillbirths. Causes, many have no specific cause. Most of the time when we do know the cause, though, it is often because of a birth defect. And after that, next most common is issues with the placenta, such as a placental abruption, preeclampsia, pregnancy-induced hypertension. And we're talking about growth restrictions, which can cause problems for the fetus, most specifically with asphyxia. And then there's other rare causes, such as bacterial infections, umbilical cord accidents, trauma, and exposures. That would be exposures to either chemicals or substances or something like that. So talking about labor, it's important to clarify here that an intrauterine death and a stillbirth are 2 separate things. They are separate events. The IUFD, the intrauterine death, is the loss of life. And the birth does not always happen at the same time. In fact, it often does not happen at the same time that the intrauterine death occurs. So these are 2 separate events. So when this does occur, when an intrauterine death does occur, there are 2 choices. She can wait for labor to spontaneously onset, which can take up to a few weeks. Yeah. There can be a medical induction of labor, which can often take a few days or more. This is really difficult for people who are in the middle of this already difficult journey to then, if they want to have their labor medically induced, they oftentimes are put in a position where they need to wait because there's other procedures that are needing to happen, or there's no beds available. And so they are still pregnant with a baby that's not alive. And that's an extremely challenging emotional journey to be on. So in this slide here, I want to talk a little bit about healing. And this is not just what the family may want to process out loud. It may be just what they are running through in their head. And so I hope that in hearing and seeing these bulleted points that you can take what seems applicable to you to apply to your own practice, your own life. And when it seems maybe not appropriate to ask some of these questions, to rather just have a sense of knowing that this is likely things that the parents are thinking anyway. If it's someone that you're close to, the birthing person may want to share and process how they were told about the loss. Did this happen at an ultrasound? Was it a situation where the sonographer had to leave the room and they were left alone for a period of time? What did that feel like? Who was there with them? Did it happen during a pandemic time when they were maybe alone? Did they have to drive home after that? If we are talking about a situation where the pregnant person expresses concerns such as, I haven't felt the baby move, or I haven't noticed as much movement, or I feel like something is wrong. Were their concerns taken seriously? That may be something they want to process. This is pretty anecdotal evidence. In my experience, about half of women who experience pregnancy loss state that they felt as if something was wrong and they tried to express it and were not sure how to communicate it in a way that it was taken seriously. Another thing that the family may want to process is, how did they share the news with people? And what was that like? Were they having to relive it with each person that they had to tell? Maybe they haven't told. Was there a discussion about birth preferences? So this would be in a situation where the birthing person is birthing their stillborn baby. And did they have certain preferences, and were those preferences followed? Were they adhered to? Did they have a bereavement doula present? Was that helpful? Did they choose to meet their baby? How did it feel when they held their baby? What were they thinking? Did they choose to name their baby? Undoubtedly, one of the most difficult things that people report experiencing is being the most challenging thing that they experience is leaving without their baby. That last time that they have to hand their baby back to the nurse and leave the hospital without their baby. They may want to process that. What was that like? What do they remember? Do they remember staring at the floor and noticing what the tile looked like? Those kinds of things. Being able to say that out loud can be very therapeutic. They may also want to talk about the hospital environment that they were in. Were they near other families who were having babies that had different outcome? That can be overwhelmingly difficult, especially after the fact, because at the time, the birthing person is likely in a state of shock and may not recognize or realize until later that they were hearing other live babies being born around them. How did they choose to manage the deceased? Did they choose to have an autopsy? Did they choose burial? Did they choose cremation? Did they choose to have a funeral? And what was that like? So just some things that may be on their minds. They may want to talk about. Substance use induced stillbirth. So overwhelmingly, substances increase the risk factor of stillbirth. When we're talking about tobacco, it's direct use of tobacco. When the pregnant person herself is using tobacco, it's 1.8 to 2.8 times increased risk for stillbirth. In passive exposure, such as secondhand smoke, it's 2.1 times increased risk. For marijuana use, it's 2.3 times increased risk. And then stimulant use, prescription pain relievers, and alcohol are all about the same, right around 2.2 times increased risk. Twin loss. So a loss of a twin or multiples. Now, as I mentioned earlier, due to advancements in reproductive medicine, this is very much on the rise, especially since the 90s. But within this drastic rise that we've seen in the past 30 years, the last 5 years have slightly declined from what we have been seeing prior to that. So twin births occur about every 32 in 1,000 live births. And then triplets or more occur around 88 in every 100,000 live births. So there's a few different ways that a loss of a twin or a loss of a multiple can transpire. So a vanishing twin is an early first trimester loss of one or more fetus where the fetal tissue is absorbed into the placenta. It can be an intrauterine death, in which case the pregnant person must carry and deliver both babies. Or it may be a selective reduction where there's a loss due to a medical intervention. What is the experience like for the birthing person in the family? Well, oftentimes if there's a loss of a twin or loss of multiples, and there is a living fetus still, the duration of the pregnancy is high risk. And so oftentimes the mother is on bed rest. That can be really difficult to cope effectively with losing one of your twins if you are stuck on bed rest and unable to use and utilize and engage in coping skills that may otherwise really help you. It can be a lot of really conflicting emotions too around loss of a twin or loss of multiples. So this is, maybe a sense of relief of it's sure going to be easier just to have one, but maybe feeling guilty about that. And then almost certainly a profound sense of sadness, just confusion around all the conflicting emotions. And then there's this loss of identity. Not very many people become a mother of multiples. And if you lose one of your twins, this identity is now lost as well. So that's another consideration of what that experience is like. Neonatal loss. This is infant loss in the first 28 days of life. Leading cause of infant death. So stillbirth accounts for more than prematurity and SIDS combined. 20% of neonatal loss occurs because of congenital abnormalities, those birth defects. Preterm birth, maternal pregnancy complications, SIDS, injuries, and suffocation are other causes of infant death. Infant death occurs approximately 4 in every 1,000 live births, and about 23,000 newborns die every year in the United States. So the language, the verbiage around SIDS has changed slightly, and this was actually new information for me. And so now the term that is being used as sort of an umbrella term is sudden unexpected infant death. And SIDS is a form of sudden unexpected infant death. And so it's a term used to describe the sudden and unexpected death of a baby less than 1 year, in which the cause was not obvious before the investigation. And SIDS is one of those forms that SUID can take on, which often is attributed to accidental suffocation in a sleeping environment and other deaths from unknown causes. NICU families. So the neonatal intensive care unit is where very sick newborns go. Approximately 10 to 15% of all babies born in the United States end up in the NICU. Most often this occurs because the baby's born premature. The next most common event is a birth defect, congenital abnormality, cardiac complications, respiratory issues, feeding issues, infections. It's the most recent information as of this year in CDC. So what's that like for the parents? Well, oftentimes the parents have witnessed some sort of code blue event where there's this incredible sense of urgency and their baby is taken and whisked away. Maybe they're taken to surgery. It's often a very traumatic experience. There's almost always at least some level of uncertainty of their baby's fate. And depending on what the makeup is of the geographic layout of the hospital, parents in the NICU may be hearing that hospital lullaby that goes off every time a baby is born. And that can be extremely triggering to be so uncertain about what's going on with their baby and hear so many babies born healthfully. And if we're looking at parents, this is birthing people, partners, parents of NICU babies, about 30 to 60% have a diagnosable perinatal mental health disorder. It's a really high number. Elective termination of a pregnancy. This grief follows the person or follows the couple for a lifetime. There's often a really complex set of emotions that come with this. Grief, sadness, potentially regretful feelings, maybe some relief feelings. And then just mentioning here political unrest as a trigger. This is something that's talked about a lot and people have very strong opinions about, and that can be very triggering for someone who has gone through this. They often will have to disclose their elective termination in their obstetric care for the rest of their lives. And they may not have a whole lot of social support following this. So just some other considerations. After a pregnancy or infant loss, parents might be coming home to an empty nursery. And that can be something that they might not really be sure what to do with. Depending on how far along the pregnancy was, the pregnant person may be lactating. And she then has to decide what to do with that. To call her provider to, get medication, hormones to suppress lactation. Maybe she chooses to, pump and donate. There's various ways of honoring, the loss, but regardless, it's another thing that she has to think about. There's also this potential guilt about subsequent births. And what I mean by this is a person has a pregnancy loss and then goes on. If you remember, I had explained that 80% of people who experience a pregnancy loss will go on to carry a pregnancy to term. And so they may have had a pregnancy loss followed by a live birth and they have a child, and yet they grieve this loss. But if they had the baby that they lost, they wouldn't have the child that they have. And there can just be some really complicated emotions and feelings about that. Another unique consideration that's a part of our world right now is, what has this been like for moms during COVID? I've talked to lots of moms who have gone into the emergency room for bleeding, and they've had to go through the entire process of miscarrying in the emergency room by themselves. Their partners weren't allowed in. What is it like when you can't be around your family when you're sad and you need support? And this is never something that's easy to cope with by any means, but it certainly makes it much harder when we are so physically isolated from others. Cultural disparities. So Black babies are dying at alarmingly high rates across the country, over 2 times the rate of non-Hispanic whites. So if you see here, per 1,000 live births, there's 10.8 non-Hispanic Black babies that are dying. And then if you look at their non-Hispanic white counterparts, it's less than half of that. Second most common is Pacific Islander, American Indian also have extremely high rates. And this goes back to, were her concerns taken seriously? Did she express concern about maybe decreased fetal movement? Was she listened to? Was she heard? There's not a whole lot of information about specifically why these cultural disparities exist, but anecdotal research supports that oftentimes Black women may not feel as heard. Partners often feel forgotten, isolated from the experience. You see about an 80% divorce rate after a loss. They may have attended birth and labor classes and felt very prepared to help their pregnant partner, birth a baby, but now what do they do with this information? And how do I support? I don't know anything about this. What am I supposed to do? They likely have a desire to be protective, but they can't do anything. And that might feel really helpless. There's a lack of specific support for partners. And partners are at an increased risk for perinatal mood and anxiety disorders as well. Now, there's not, that I'm aware of, any specific information about partners' rates for mental health after a loss. But if we look at the related information, we know that 1 in 10 fathers experience a perinatal mood and anxiety disorder in the event of a live, healthy birth. It's still 1 in 10. And then we also know that 3 in 10 fathers who have a Nicu baby will experience a perinatal mood and anxiety disorder. So we can speculate about what that might be following a loss. Grief is not linear. You see this lovely little diagram on the left of all the stages of grief. But anyone who's grieved a loss such as this may relate to the fact that it feels a little bit more like the diagram on the right. To grieve, we have to feel all of these emotions, and while they're very uncomfortable and very painful, they are necessary for healing. And it's messy, and sometimes it doesn't make sense. What do they need? What are the interpersonal needs? What does the couple or the birthing person need from other people following a loss? So first, we'll talk about the things that are not so helpful. So those silver lining statements, those are not typically helpful, and it can be very difficult because in our society, death is a very taboo thing to talk about. And because others are uncomfortable with it, there is an attempt to cheer them up. But people who have suffered a loss don't need or want to be cheered up. Statements such as, "Why don't you just adopt?" are not very helpful. Avoiding the parents is probably one of the most harmful things that can be done, because the parents sense when people are avoiding them, and it feels very isolating. When people avoid talking about the loss, it often feels as if people are avoiding talking about the elephant in the room because they don't want to be uncomfortable. Reassuring them that they can try again. It wasn't meant to be. or with it, regardless of the intention, encouraging them to move on is also not helpful. Attempting to give a reassurance that their lost child is in a better place is not particularly helpful. Another thing that I put in here is when we're human, and as caregivers and as care providers to someone who may be experiencing this, it's reasonable to have our own emotions about this. And if you are a caregiver who works with families who are experiencing this, it's important to have the understanding that the parents can't feel responsible for our emotions too. They're overwhelmed with their own. And so we as caregivers have to be able to cope with our own emotions without putting that on the bereaved parents. What's more helpful? Well, keep the memory alive. Say their name. It means that their life meant something. Say, I'm sorry. Do you want to talk about it? What are you thinking about most? Take them to the side and acknowledge the loss directly. People often say, I don't want to upset them. They're likely thinking about it anyway, or I don't want to remind them. And they didn't forget. It's helpful just to say, I love you. You can help them make memories, keep mementos. Another important consideration is that at first, in the first couple of weeks, they're going to be inundated with casseroles and sympathy cards and things like that. And when bereaved parents need the most help is 2 weeks later, 2 months later, when everyone else has gone on with life and they still don't have their baby. That's often when they need the most help. Postpartum healing and needs for the bereaved person. Oftentimes it's very healing for them to be able to claim their story when they are ready. Through claiming their story, they are able to claim the pain. It can be a invaluable gift to others who are suffering in silence to be able to share that pain and share that story. They may wonder or have a need for validation about whether or not they are honoring the loss enough. Are we honoring our lost daughter, our lost son, our lost baby enough? It can be very healing to find meaning, a purpose, a way to help others. The most important thing is that most often bereaved parents want to talk about it, even if it's not a typical happy ending. Honoring the loss. After a loss, it can be very helpful for support people in their lives to help them honor the feelings that they experience and affirm the relationship that they had with their lost baby. It's okay that you're sad. That was your daughter. That's your daughter. That's your son. Affirm that relationship. Yes, that is your child. Validate the need to maintain connection and then help them maintain that connection. I want to share this photo. One of my closest childhood friends gifted this necklace to me following my pregnancy loss. And my oldest daughter, Landry, was about 2, and I lost a daughter. And this friend was the only person who was really there for me during that time. And this is one of the most treasured things that I have, because she recognized that my daughter's life meant something and meant just as much as my living daughter. And I really treasure this necklace. So I wanted to share that. Going back to the Star Legacy Foundation, a nonprofit, they're out of Minnesota, but they're a national nonprofit. So there is an international wave of light that is going to happen on October the 15th at 7 p.m., where people are asked to light a candle to honor our babies that are amongst the stars. there's at their website, you can copy these, or there's many other banners, images, and share on social media. Hashtag never be still. Shatter the silence and say their names, which brings me to saying the names of the babies that were lost. So at this time, I want to take a moment to recognize our babies that are out amongst the stars. And I want to recognize a loss of expectation of a grandchild from Akari. 2 lost babies, Joy and Dove. And my daughter, Loxley. And if anyone else would like a name said aloud, please feel free to mention that in the comments. And at this time, I'd like to take about a minute to have a moment of silence to recognize the meaning of their lives. And when we're all ready, we'll take a breath. I'm going to talk about some resources to help families. Postpartum Support International has a helpline that I have listed here. It's a 24-hour warm line. So while there's not always someone to directly answer, callers can call at any time and then receive a call back. I believe it's within 4 hours. And that phone number is listed there. I also have some resources here in various capacities for bereaved families, which I'm happy to share if, Jenny, if you want to put it on the Facebook page or anything.
Yeah, I'd love to be able to share these on our social media. Thanks, Caitlin.
Yeah. And that's all I have for you all. So thank you for allowing me to speak on this topic.
Thank you for sharing all of that. I think that was, it was a really wonderful presentation. And I think it was really thorough, and also allowed a lot of us, myself included, to think through a lot of the things that, we assume are happening maybe in people's lives, but we aren't thinking about. I think it was, just so well done. Thank you so much, Caitlin. I really appreciate that.
Yeah, thank you for giving me the opportunity.
Yeah. Well, so those who are joining us on Facebook Live, now we're going to pop off of Facebook Live so that we can share and ask questions kind of offline. So if you'd like to join us, go ahead and join the Zoom, but I'm going to pull us off of Facebook now. All right. I'm going to stop recording too.